think I'm gonna go ahead and start. Well, good afternoon, everyone, and welcome to today's colloquium. I'd like to start with some housekeeping and then go on to the introduction. So we'll be hearing a talk on global oncology, after which we'll be opening the floor for Q&As. If you have questions during the talk, please feel free to type it out in the Q&A box. This will be read out after the talk. However, if you have the opportunity to raise your hand and ask questions if you prefer to speak at the end of the talk. So my name is Esther Annan. I am a postdoc research associate with the Center for Health and Wellbeing, and I'm honored to welcome our speaker for today's colloquium, Dr. Christina Stefan. Dr. Stefan obtained her medical degree, master's degree in pediatrics and oncology, a master's in cancer epidemiology, and a PhD in medical education, as well as an MBA. She is the first woman elected president of the African Organization for Research and Training in Cancer, and was voted as the most influential African woman in business and government in 2016, as well as among the top 100 women leaders in healthcare in Asia in 2020. She works as advisor for ministers of health in different countries and consultant for WHO and World Bank. Stefan was a key partner in last year's Health Equity in Africa conference and appeared on the Princeton Pulse podcast discussing Rwanda's efforts to eliminate cervical cancer. So if you have not listened yet, please do. And help me welcome Dr. Christina Stefan.
Thank you so much, Esther, for this introduction. That sounds really like a lot. So that adds maybe to the expectations of this webinar. Thank you for the invitation. I mean, I'm very excited to be here and to be able to share with you and to talk about a subject which is really very close to my heart, and this is global oncology, and more than global oncology, really about equity. I'm excited to be able to, present this, lecture. I wished very much to be together with you in Princeton. I have really great memories from my last visit there a few months back. And I think we could have had much more fun and have a real interaction with the students while present in the classroom. But any case, let's make the most out of it. So, for today, I decided this is the structure of the presentation. I will start really with a short introduction about my personal global health journey. I like really to introduce myself to the students, to the audience, to really understand a little bit about my journey and from where I started and where I am now. Then I will talk a little bit about cancer in Africa in general, an overview. Of course, this is a global health webinar, and part of the global oncology, I wanted just to give you a general overview about cancer in Africa. And maybe some of you would know there are 3 WHO global initiatives on cervical cancer, on breast cancer, and on childhood cancer. And I'm going to touch on 2 of those, on cervical cancer and on childhood cancer. And then, of course, about the main topic, which is global oncology. What is global oncology? How do we achieve equity? And what is the correlation between global oncology and equity? And perhaps the most interesting part, I would say, at the end, some reflections. And not only reflections, but also, thinking about ways in which we could reduce these inequalities and the role of innovation. And then I would expect really your input and to brainstorm together. So this being said, my personal global health journey is summarized in one slide. It looks quite busy. And when I started many, many years ago, becoming a medical doctor, I never imagined that I would be really getting myself into a journey in global health. But I'm extremely happy that it happened this way. So I became a medical doctor in the country where I was born, and that was in Romania. And I'm sure that you would not recognize me here. So this is how I looked when I finished the medical school. And from there, I moved shortly after finishing the medical school to South Africa, where I spent most of my medical career working in South Africa and working in many other African countries, where I became a pediatrician and later an oncologist. And you will see that part of my lecture. I like being a pediatrician. I like telling stories. Lots of them are real stories. And I would use a lot of pictures because sometimes, you know, we relate to stories and we relate to pictures. And of course, we all know that sometimes a photo means more than 1,000 words. So hopefully I'll be able to share with you. And most of the photos are taken by me in different countries, in different situations. But I think some of them, they reflect the reality of that moment. So treating children in Africa was, for me, one of the most demanding experiences, but also one of the most rewarding experiences, as you may just imagine. We had patients who came really with very advanced form of disease, but also patients who really responded very well to our treatment, and especially due to the progress which we made in the last years, we are able to save more and more children diagnosed with cancer. As Esther mentioned, I became the president of Aortic. So I would really like you to know about Aortic because it is a great organization dealing with research and teaching in cancer. And it gave me also the chance to work in more than 30 African countries, being involved in teaching, in research, community work, doing training programs, and so on. After a while, I moved and I experienced pharma, and I became the global oncology leader for Roche, and this time in Switzerland. And one might ask, okay, but why? That's completely different. Yes and no. It was really my interest to be able to be involved in innovation and looking for diagnostic tools which could be affordable and could be used in low mid-income countries. So that was the reason which made me really lead at the global level oncology, having in focus the need of having appropriate tools for the patients living in low mid-income countries. And from there, the career took me to Singapore, as you can see, with some of the colleagues in my team, this time again being in charge of innovation, something which is very, very close to my heart. Responsible for 18 countries in APEC region, Asia Pacific, again with the same aim, making a difference or a contribution for Southeast Asia. And for those who are coming from that region, Foxconn in Taiwan. But not long after that, coming back to my roots, back to Rwanda, back to Africa, trying to use everything that I learned and I did, leading the Institute for Global Health Equity Research, part of UGHE, which is the University of Global Health Equity. And I'm sure that all of you heard about PRH, so part of the partners in health, a tremendous experience. And I know that some of you, maybe some of the panelists, have been already to Butaro. This is the University of Global Health Equity. Sometimes we refer to the university of being a university in the middle of nowhere. And it's actually in the middle of a village, in the middle of a community, in a very rural area of Rwanda. And it serves the purpose of really having a very close interaction between students who live in these buildings and their teachers, sometimes perhaps difficult to find, but to remain constantly on the campus together with the students and interacting on a continuous basis with the population, with the patients. So let's move now to the lecture. Coming from South Africa, you will see that I will use some of the statements and some of the photos from there. And of course, for the lecture for today, I could not miss this occasion to bring this statement of Mandela. I'm sure that everybody heard about Nelson Mandela, who has been not only a Nobel Prize laureate or an idol for South Africa and an idol for Africa, but I believe he was and he still is an idol for everyone in the entire world. And he said that health cannot be a question of income, it is a human right. So before we start and before we go into our global health equity and into our global oncology, I thought that it would be really important for us to make sure that we talk about the same things. Because in most of the cases where you are in a group or in a discussion, people have different understandings when they talk about health. So what do we mean when we talk about health? And again, this is a picture at the outskirts of Cape Town, completely different than what you can see. And this is a medical center situated in a rural village. So people, when they talk about health, most of the people, they refer to health care. And again, health, it's not only health care. So the conditions where we were born, and I'm going to underline the geography, the place where we were born, where we work, where we play, definitely affect our health and outcome. And again, a small classroom in a village compared to a child that has no place where to go to play or to learn, again, not far from Cape Town. Randomly, I decided to draw your attention about something that I'm sure you're very much familiar or you learn during your course about the huge disparities between the countries. And I've been to both countries, to Central African Republic and to Hong Kong. And what you see here, it's obviously a huge difference in terms of life expectancy between the two countries. And again, randomly, because we are going to talk about children, we are going to talk about children with cancer. These are children in Angola, absolutely amazing people, extremely welcoming. And these are children in Finland, also gorgeous children. But then when you look at this number, obviously you will relate that the chances for a child in Angola to die is 90 times higher than for a child in Finland. So perhaps something that we could reflect and maybe something for the students to think of, since I don't have the chance to interact with you in the classroom, but I can still ask questions, would be, of course, it is not fair. Of course, it is not equitable. What do we need to do? What would be some of the solutions that we could reduce this gap? And a child born in Angola would have a much closer, let's say, outcome or quality of life, access to care than a child in Finland. So think about that, and then perhaps at the end of the discussion we can discuss. So when we talk about health equity and when we talk about cancer, and again, these are pictures which I took them recently. So they are real pictures and not just on the internet. One keeps on thinking, okay, we talk about equity, we talk about cancer, but we do understand that the social determinants of health play an important role. And I mentioned geography. And also for the sake of this presentation, I said, okay, let's show some nice photos as well. So obviously natural parks and beautiful animals. But the question remains, can we really remove geography from the thinking and speaking in neutral terms? People perhaps who do not have jobs, and people with low income, and people who do not have access to any healthcare. So again, how do we define health inequity? And again, there are so many definitions. And as you can see, I decided to choose choose two of them. One of them is from 1992. And for those who know me, they will remember that I usually I do not like to use old references. And I ask the students, not to use old references. But for this presentation and for this type of definition, I wanted to use something that was, about how many years, about 30 years ago, and to see how does the definition in 1992 relate to, let's say, 20 years later. And both of them are extremely valuable and bring to the point the health inequity. And also, I wanted to share with you something that was important for me and made me think, and that was defined by the fact that, as a general rule, constitution and the habits of people follow the nature of the land where they live. So if you pause for a second and keep reflecting about this statement, and more than that, we added also their cancers, because it's definitely a relationship. And this is a photo taken about 2 years ago in Myanmar while doing ward rounds in a hospital there. So briefly about health equity in Africa. I wanted to share with you a short historical perspective of health equity in Africa. And most probably, again, they are known facts, perhaps just to refresh your memory. And this is related to weak health systems, because when we talk about health equity, definitely we will talk at one stage about health systems. And weak health systems have deep historical roots. And we also know that a number of countries in Africa which have been colonized and exploited have the weakest health systems. And of course, we know that, as I mentioned, health is not a basic right as it should be. And just to remind you about barriers to health equity, what is accepted or not accepted, but as barriers, we would say health resources which are available or not, which are not available, health resources accessible, acceptable, and then not lastly, we talk about quality. So when we talk about quality to health, we include everything from really having the patient in the center of everything that we do, to integration, being effective, efficient, safe, and so on. Lastly, I will just remind you about the cycle of poverty and poor health, which again is an interlinked or intertwined between political, social, and economic injustices, war, not only in Africa, unfortunately, war in many other countries, but Africa also, has its part of wars and internal conflicts associated with people not having any work, who are not employed, with no income or very poor income, associated with poor nutrition and lack of clean water. So this is just to make sure that we are all aligned in terms of what is health. When we talk about health, a little bit of an overview of health equity in Africa, understanding the barriers, and moving towards cancer in Africa. Again, this is a picture taken in a ward in Senegal. Some of the children treated here. If we talk about cancer in Africa, I don't want to disappoint the colleagues from statistics, but I decided not to use any graphs with incidence or survival for several reasons. One, because from my own experience, you will not remember the numbers. And secondly, because those numbers that we usually learn about it from GlobalCan or from any other textbooks, I believe do not reflect entirely the situation the current or the existing situation in Africa. So I would rather prefer or ask you to know that most of, because I understand you are a mix of students from different disciplines following maybe social sciences or political sciences or other, maybe some of you med students. But what I would really like you to focus on or to remember will be the fact that most of the cancers occur in low mid-income countries. And when I say the most, they are associated also with the most of deaths. And again, the situation does not seem to improve, but rather the disparity to get worse, is worsening, and the gap between the countries which do have access to a good healthcare and those which do not have is getting bigger. And I said, I think, we are dealing with more cancers than those that are presented, because most of those numbers are estimates. And this is really easily explained by the fact that most of the registries do not exist in Africa, or if they do exist, there are really local registries, hospital registries, or they do not have a comprehensive data. And I use this 32% decline in cancer deaths just to illustrate that progress has been made, that it is possible really to reduce the burden. However, this is not reflected on the African continent. This is a photo again, which I took, unfortunately, of not such a good quality, close to Butaro Hospital. It is really a beautiful place, lots of, hills and lake. And here what you can see, there are two women together with two small children. I don't know if you'll be able to see them or not. One of them is trying actually to help his mother. And while looking at this picture, it crossed my mind that, those women, the global burden of breast and cervical cancer is huge. And we know that every minute a woman dies of breast cancer, and every 2 minutes a woman dies of cervical cancer. And we know also that most of these deaths are premature and also preventable. Maybe the situation in Rwanda is definitely much better, being a country which really made a tremendous progress. I would like to share with you some of my research, I think, which illustrates as well in the context of global health and global oncology and equity. Very briefly, one of them was work done together with WHO. It was an assessment of health systems in 6 African countries. So WHO Afro, so the WHO based in Africa, wanted to determine or wanted to find out how ready are the health systems in those 6 countries, looking really at the readiness in terms of health systems. And for those who are not as familiar with the African continent, here you have a map with the illustration of those 6 countries which took part. Guinea on the western side, and then we had Uganda, we had Rwanda, we had Malawi, Zambia, and then Swaziland. Swaziland now is Eswatini. It was a big questionnaire with about 130 questions, trying to understand as much as possible and plan for the future. What is important, and of course I'm not going to go into details of this survey, we are talking about really a huge female population of about more than 55 million, a number of women diagnosed with cervical cancer, and also women who died due to the disease. Something interesting perhaps the fact that most of the women live in rural areas, and I wanted to draw your attention about the correlation between HIV positive women and the literacy rate. So education between two countries. So Swaziland, 32% positive with literacy rate 95, compared to Guinea, 1.5 to 22% literacy rate for the women living there, which was really very interesting and made us think about, quite a number of hypotheses. We looked at primary prevention, secondary prevention, tertiary prevention, governance, management. Of course, I'm not going to go into details about all these elements. The paper has been published. Training and specialists, again, great need in all oncology, and improvements needed with a number of recommendations adapted or tailored for each country depending of their needs. Like, for example, countries with no radiotherapy facilities, or countries with no chemotherapy drugs, or no HPV vaccination. And this slide summarizes the great disparities in mortality from a preventable disease. As you know, by 2030, there is the effort that we would try to eliminate cervical cancer as a public problem, as a public health problem. And unfortunately, Africa has 19 out of the top 20 countries with the highest burden. And we know some of the causes, and they are related to human resources, such as pathologies, distribution of physicians, nurses, pathology. And that made us think and determine our next research, which has been published recently in the Journal of Cancer Policy, for those who are more interested in cancer, published about a month or 2 months ago, looking at the current status of national cancer control plans in Africa. So we have data from 32 countries. It's actually a survey which we are repeating 5 years from a previous one. And what is interesting to see is, and I would like to draw your attention about the universal health coverage available in 40% of the countries, and we are talking about from 32, so about 14 countries or so, and only 47%, so less than half, on cancer screening policies and practices. And of course, we looked at the causes, and we came up with some possible solutions. So inequities in the conditions of daily life, by inequities in power, money, and resources. And of course, it's easy to think that a rich country will do better than a country with less resources. And of course, the amount of money which is spent on health, so health expenditure per country, which will determine the outcome. So briefly with you on the second WHO global initiative, and this is on childhood cancer. Again, 2 children, one child, a photo from Cambodia, and one from Transkei with an extended disease. And this is one of the first meetings that we had in 2018. As you can see, many people that I'm somewhere here, from all over the world, trying to brainstorm, trying to sit together to analyze and see how we could change this situation. In the meantime, there are plenty of working groups trying to find solutions for increasing or saving 1 million lives, children, by 2030, and increasing the survival to 60%. And again, I just need to perhaps let you know that in some of the countries, the survival in childhood cancer still remains very low. So when I say very low, 5%, 10% compared, let's say, to statistics in the United States, which now children can be cured in more than 90%, especially in common diseases. So retinoblastoma in United States, really limited. In Central America, maybe more advanced. One other research that I wanted to share with you is really related about the patterns of distribution of childhood cancer in Africa. And also, invite the students while they read articles to read in between the lines and also to reflect on what they read and question. I would say always, question and think and understand well the data which it is represented. And one of these examples is represented. Again, let's just look at brain tumors, which are marked in red. If you look at red anywhere here on the map, you will see only that red dot here. But of course, the conclusion is not that the brain tumors are only present in South Africa, but South Africa is one of the countries which has the investigations, the CT scans and the MRIs, which allow the diagnosis of brain tumors. And that does not mean there are no brain tumors in the rest of Africa, but either they are not diagnosed due to the lack of facilities, or sometimes because easily a brain tumor can be mistaken by a cerebral malaria. And again, if we look, 28,000 children died of cancer in 2020 WHO. The number as such does not say much, because 28,000 children out of how many? Even, of course, the life of every single child matters, but it must be seen in perspective, and this is just a recorded number. I believe the number is much higher because they are, again, children who are not diagnosed or who are not reported. So I would like to underline that the burden is actually much, much higher. One other interesting research that I would like to share with you is related to the incidence of HIV. So in the first decade of the 21st century, as you all know, we had really a crisis with a huge number of children diagnosed with HIV/AIDS, and they were living in South Africa. And we managed to have one of the largest, actually the largest cohort of children with HIV and cancer in the world. And then we were able to look at the prevalence of various cancers and find some major differences between, let's say, those presented in the United States as compared to those in Africa. And the same regarding the role of ARVs, which is antiretroviral treatment, combining chemotherapy and adapting the protocols according to the toxicity and to the side effects. I would like to pause for a second here and talk only for 2 minutes or so about Burkitt lymphoma. Again, it is in the context of global health. You may know that Burkitt lymphoma is one of the most common childhood cancers in Africa, especially in Eastern Africa. And why I thought I should share with you this story, because it is a story of success. Even if it looks impressive, especially on the left side. This was a father whom we met a few years back in Ethiopia. So I went to Ethiopia, to Addis Ababa, to Black Lion, that is the main hospital, the public hospital, at the invitation of one of my colleagues who was leading the department of pediatric oncology, and we did a ward round. And while we finished the ward round, we decided to take the stairs and to go, to move to the lab. And on the stairs, we had this father who was basically following us, and the child looked at that moment in time like this, and kept on asking us, please do not give up on my child, please help me. He was a father who was not at the time in the ward when we did the ward round. So of course, we looked at the child, we made the diagnosis of Burkitt lymphoma. And this is one of the most curable cancers with appropriate with appropriate treatment. And as you can see, this is the child now. A few weeks after the treatment, he's doing very well. He's got a medal here. He's doing very well at school and also in sport. And that made us, come up with another idea. And we said, okay, what are we going to do about so many children with Burkitt lymphoma in Eastern Africa? They don't have the finances to be cured. So we introduced a new program, which was called Adopt a Child for United States. It wasn't really an adoption per se. It was really matching a family in the United States who wanted to, pay for the treatment of one of those children. The treatment for 6 weeks cost only $50. So really not a huge amount. But as you can see, the outcome was spectacular. So it was one very good project, many people involved and being willing to pay these $50 to save the life of children. And again, another snapshot 20 years ago when we had fewer treatment, before and after treatment, children who are doing very, very well. So global oncology. This is our subject. What is global oncology? And again, we need science that questions why the world is the way as it is. So I might start by telling you that perhaps we do not have yet a definition on which we all agree. About a decade ago, I think it was a common global health definition agreed by the Consortium of Universities for Global Health. I think at one stage there were more than, 170 academic institutions. So really a huge number of institutions, universities, partners joining forces together to make a difference. What determined the global oncology was the need to address the substantial health disparities, especially in terms of cancer, and especially if we talk about estimates, which are quite frightening if we are not going to find some solutions and trying to really reduce this gap. So global oncology emerged as an academic discipline which seeks to promote scientific and clinical advances for cancer care everywhere. Even if we don't have a definition, we know that the mission is to bring the best in cancer care to underserved patients. And you will hear many times about an academic career, about initiatives, about trends, about research. And it's interesting again, because when I talk about global oncology, at one stage I stopped and I asked some of the students, what is global oncology? And I was quite impressed that one of them said, for me, global oncology is to see the forest beyond the trees. All right, so it was quite an original definition, but I said, okay, perhaps we should use it. And then I added here so-called a registry. So that's the way of how some of the hospitals keep the records of their patients. So why global oncology? And when we talk about global oncology, of course, it has to do with oncology. It has to do with global, with no borders. And we talk not only in Africa, we talk about Southeast Asia, we talk about Eastern Europe, we talk about South America. We talk about a tsunami which is going to hit the medical system and cancer if we don't do anything about that. And we do understand better that a global coordinated approach is really needed. And because you are at Princeton, quite far from you, I decided to bring an example from your neighbors at Rutgers. And this is a great example of how they do global oncology in Botswana, a partnership which involves research, education, and so much more. One of the papers talks about the needs in global oncology, and one of them was mutual learning, because obviously low mid-income countries should learn from high-income countries, but the other way is also true, high-income countries learning from low mid-income countries. More funding, of course, more money, but if the resources are limited, what else can we do? And I think it is important to underline the collaboration. And from my perspective, I think innovation. And again, thinking about global oncology, I believe that global oncology is not the concern of low mid-income countries only or alone, because we all know cancer respects no boundaries, and neither should cancer control efforts should do it. So when we talk about global oncology, of course, we talk about training, we talk about research, we talk about innovation, and not only, I would say, even about leaders and the global oncology career. And this is another patient from the ward where I wanted to perhaps come up with some other ideas, such as Global Oncology Institute, where we could have global oncology curriculum, we could have a master's in global oncology, which is all based at the level of interdisciplinary collaboration. One suggestion would be begin in one country and prove change is possible. And as you can see here, I have a question for you as well, this time as well. There are plenty of programs and partnerships and collaboration in global oncology or in any other field, because obviously when you talk about global health, you can talk about child and maternal health, infectious disease, tropical disease, and so on. The question to you would be, what would make a program more successful than the others? Or how would you know that a program is really successful or more successful than so many others? And why do some of the programs succeed and some others sort of stop along the way? So for the students, maybe think about that, and let me have your responses in the chat. So the last few minutes before I close, I wanted to share some thoughts with you, and again, hear your opinion in terms of the path forward. How could the future of global oncology look like? We know how it looks now. We try to understand each other. We try to work together. We try to collaborate, but definitely I believe that we need to do things differently if we want to achieve different results. And I don't think that we have much time left. We really need to move faster to reduce this gap. And again, if you just take childhood cancer and health equity, and again, this is rather specific. We agree that equality doesn't mean equity. There are a number of actions that we could take. If we think in terms of global pediatric oncology research opportunities, again, we could work across borders and do a lot of projects together. But the question is maybe a rhetoric question. And this is, who will be actually setting the global health equity agenda? And we know power and equity are key. And we also know that decolonizing global health is not just a matter of adding new diversity, equity, and inclusion programs. It's a much deeper approach. I would say from my side, focus. That would be something that I would like you to consider. And of course, we have things that you can measure, no doubt about that. But sometimes not only on things that can be easily measured, but also on things that matter, but couldn't be counted. And I refer, for example, to new voices heard, which is difficult to really quantify, but they are just as important, or prioritize how people who know or who get involved will go about reshaping it for better. Of course, we talked about money and power, and we know about key and emerging priorities of health equity. I'm sure you have learned during your curriculum and your class about investments in health insurance, about leadership and political will, and we do have examples, maybe not as many as we would like to have. We know about building strategic partnership. We know about different interventions, about capacity building and research. And we also know about leaving no one behind. The question is this enough? Shouldn't we do something else? And I'm thinking in terms of how Africa, because I did speak quite a lot about Africa, how can Africa adopt and advance health equity? And of course, when I talk about health equity, I'm thinking in terms of global oncology as well. It's not only could be health equity, but could be global oncology as well. And one example would be local capacity building for community health workers. We know about leadership, we know about reducing poverty, improving the economic stability, we know about equity-driven policies. Is it anything else that we are missing? Anything else that we should really focus more on to obtain the results that we would really like? And I'm ending the presentation, hopefully on time, with two other pictures. One, again, a university in a rural area. I mean, there are other universities coming now, many other centers of global health in different rural areas of villages. I think it's a good example. And on the other side, equity. And I believe that we could use, and of course the textbooks and the definitions are great and are important, but nothing will bring more value than you, for example, as students, to going on the field. And I know you have your internships or your rotations, really mixing with people, talking to the patients, spending time within the ministries of health, within an NGO, within a hospital, within a university, learning and coming up with new ideas which could help us. And this is another example of students coming from all over the world, trying to have either research questions or teaching in different schools or working in community centers. And of course, I said that I will bring some more South African flavor. And this time is the South African flower, Protea, and maybe something to inspire you and to think about. He who sees things from the beginning will have the best view of them. So for those who are really passionate about global health, I think that's you who can make the change that is so much needed. And for those who are into more technology, you have my LinkedIn here and my email. I love students. I love to be challenged and to interact with them. And feel free if you want to communicate or to brainstorm or be in touch with me. And this is my last slide, where, again, as an oncologist and especially as a pediatric oncologist, I believe that together we can make the impossible possible. And this is actually my daughter when she was younger, trying to collaborate, overcoming fear and collaborate with Cheetah, and showing exactly that making the impossible possible. And thank you for your attention. And I know that I still owe you perhaps a global oncology tea on my next on my next visit to Princeton.
Thank you so much, Dr. Stefan, for exposing us to the world of global oncology. I did see a hand raised from Rick even before opening the floor. If you do want to speak, could you raise your hand again? But other than that, the floor is open for questions. Yes, Rick Marlink, you can go ahead and speak, please. Are you able to speak? If not, could you please type out your question and then I can read that out. Oh, there are questions here. Okay. From Alyssa. So Alyssa says, that was a wonderful presentation, Dr. Christina. Following the pandemic, much was written about the difference having regional vaccine manufacturing and production sites would have made. Can you speak a bit about how such sites might also impact cancer outcomes in low middle income countries?
Thank you, Alisa. I mean, that's actually a very relevant question. We talked a lot about this pandemic, and of course, we talked a lot about, having regional vaccine manufacturing production sites. So one of the approaches, or more recent approaches, was really to try to empower and have manufacturing in terms of vaccines, and not only vaccines. Now we are trying to have even drugs, chemotherapy drugs, which are produced on the African continent. So for any other, let's say, emergent pandemic or any other crisis, definitely Africa is going to be in a much better position to be prepared. I think, again, a lot has been invested in terms of pandemic preparedness, but not only, because as you can see, we talk a lot about prevention in terms of cancer. We talked even about the HPV vaccines. Are they available? Are not they available? What would be the price of such a vaccine? And how can we counteract the fact that, most of those are not affordable, to most of the African countries. So I am very much aware, not only in South Africa, not only in Rwanda, Kenya, Ghana, Nigeria, there is a consortium of African countries that are preparing, those sites, and definitely, even allowing for HPV vaccines to be prepared on the African continent by the Africans with different types of public-private partnership would make the access much easier, much cheaper, and obviously achieving at least the HPV vaccination, part of the WHO global initiative.
Thank you. So there's another question. What are you most excited about with respect to innovations and the future of cancer care?
Oh, there is so much. I just love innovation. So, I mean, I had the chance to really see the perspective from different countries and globally. So innovation, you can talk about the whole spectrum of cancer. So from prevention of cancer, from diagnosing the cancer, so the ways in which we could innovate and have a diagnostic test, and I will use an example because examples are always easier to use. Perhaps for those who will follow a medical degree, might read, might be more, let's say, up to date with the innovations in oncology. But for example, there are new blood tests where you can have a drop of blood that could be able, with a drop of blood, you could diagnose cancers. Instead of doing for example, for colorectal cancer, instead of doing invasive procedures, there are lots of studies now trying to diagnose cancer by the smell of it, which is something very unusual. I mean, still needs to be proven, but the agenda of innovation in cancer is absolutely tremendous. And I'm not even talking about the fact that, one is working now in advancing genomics. again, something that is very close to my heart, the fact that in many cases, we bring protocols from, let's say, United States or Europe, and we try to treat the patients in Africa. And sometimes we find out that that does not work and we don't understand why. So we are coming now to really understand more, because, African population really has so many differences and so many variations. So genomics is a field which is really getting more into Africa. Up till now was not possible. It is still extremely expensive. And then, we can talk about all sorts of algorithms, from prediction, from prognostication, like working, for example, imaging together with the genomic sequencing, tailoring specific treatment according to the person, and also, determining that is the right amount or not, in terms of treating, different tumors, and what could be perhaps the outcome of a patient. Of course, the whole idea is to use less chemotherapy because there will be less side effects. Then, of course, about mammography, another example where we could use AI, and which is extremely useful. Mobile units, which they will go to the most rural places, and where a woman could have a mammography and immediately have a response which will be extremely accurate, like, let's say, 98%, instead of really waiting, calling her back, sending her, or doing any other references. And we come up even with more interesting ideas, not only the mobile apps, but something like sensors, where we have some ideas where a patient, for example, is diagnosed, treated for cancer, and then has a small sensor which could be implanted in the skin, and that could have perhaps an evolution of the tumor markers. And at whole moment the whole day, all moment in time during the day, the clinician could follow of what is happening on the tumor markers of that specific patient. So it doesn't matter where the patient is, the data is fed into the computer, and the clinician could see if the patient is relapsing or not. So I don't know if I could have a list of priorities. I'm just excited about innovations in general in cancer.
Yeah, it sounds like that's a lot to be excited about. Thank you. That was really insightful. There's another question. I have a question specifically about cervical cancer in Africa. In my midterm project, group's case study on cervical cancer in Rwanda, we recommended a pilot self-collection program whereby community health workers deliver and collect samples from women in the 35 to 45 age range to conduct initial cervical cancer screening. What do you think about this approach? Based on your expertise, would self-sampling provide similar accuracy while reducing barriers to access for cervical cancer screening?
Oh, thank you. I think it's an excellent question. Obviously, it's the traditional way on which we do the screening and the collection of the samples. Of course, 35, 45, it depends, on many conditions. That's a general limit. So initially, it was not really heard or thought that women would do self-sampling. But we were discussing in Geneva a few years back about that, and there are so many studies which actually showed that self-sampling is actually producing similar results, sometimes even better. I was one of those maybe a little bit suspicious that not everyone in a, let's say, village or a rural community will accept such a collection. But definitely it is proven that self-collection works just as well. So I think it's a good, good proposal, good project.
Okay, thank you for that. The next question is, what would you recommend to a young person interested in having a career like yours? How would I start? What are the critical things to try to do early on?
These are difficult questions, So when I started, of course, I never planned to, let's say, to have such a journey. My first recommendation would be love what you do and be interested in what you do. And in my case, for example, I really wanted to be able to help. And this explains why, for example, I followed and I became a medical doctor. I wanted to treat patients, and I treated initially patients, then I wanted to treat children because I thought, they did not really have a voice to be heard, and I wanted to be on their side and to help them. And this is why I did choose pediatric oncology, because it is really a difficult specialty, no doubt about that. I never imagined it. And especially because I took it extremely personally from my point of view. So every single child that I had in front of my eyes, I thought, what would I do if this child that I'm treating now is my own child? So I knew that I cannot go wrong, or if I would go wrong, it would be because I don't know better. But I consider every single patient, every single child like my own child. And then it was extremely emotional. It was extremely rewarding because I could really see patients improving, and I became having, a very extended family, and I was part of all the, let's say, festivities and birthday parties. And even now, I mean, after many, many, many years, I'm still invited for them. So we keep a strong connection. But from treating child by child, I thought, okay, I'm now more interested. How could I bring a bigger impact? Not that, saving one life at a time would not matter, but how could I make it so I could really contribute and have a bigger impact? And that took me to global oncology and trying to really think out of the box. And then I was quite curious about things. And this is why, I joined pharma with the same idea. Can we do something different or more for low mid-income countries? I enjoyed studying. So this is why, I decided to do perhaps epidemiology to understand more, to do pediatrics, to do oncology, to learn about, I would like to teach students. So that was something that was really very close to my heart. And that made me study, how do I teach them? What should the curriculum have? And that was why I decided to do a PhD in medical education. What should a curriculum for those students who would like to go into oncology or hematology, what should they learn? And how quickly and how fast that curriculum should change. So do what you love and do your best, and for sure you will end up with a successful career.
Thank you. So from Rick and Marlink, thank you, Dr. Stefan, great presentation. How do we get that, in quote, one example of a place in sub-Saharan Africa that can prove that cancer care and prevention is possible?
That's even a more difficult question. So I would definitely like his opinion on this question. He's a great oncologist and doing global health for many years, I think more than 30 years or so. Again, from my perspective, would be really start small and focus and prioritize. And perhaps a smaller country with the political leadership and a will. And when we create a twinning program, something that is, again, very close to my heart, we make sure that we have a champion on both sides. So regardless of, let's say, current circumstances, the focus remains the same. I would introduce a new model from this point of view and focus on one or two or three things and prove success. And from there, I would move it further.
Okay, thank you. So a question from Johnson Lin. Thank you so much for this talk. I know that this talk has been focusing on cancer and oncology, but I was wondering how low and middle income countries can be included in the discussions of non-communicable diseases, especially as regions such as Africa will undergo huge demographic changes. How can this discussion about cancer inform the future of rising NCD prevalence?
Yeah, I mean, that's a good point. I mean, I'm referring to oncology, but I mean, cancer is just part of NCD. So when we talk about cancer, of course, one should not forget about cardiovascular disease, about diabetes, because I mean, Africa unfortunately has the burden not only of one disease, but several diseases. And I'm not talking about infectious disease, but really referring to the question where we talk about NCDs. So again, it will be, and we are undergoing huge demographic changes. And I mean, if we look at the population or expectations of the population in 2040 or 2050, I think, 1 in 5 would be an African. I think, it will be extremely important to understand what is the cause. And again, to focus, because even, from the political point of view, even from the government point of view, even let's say for Rwanda, which made tremendous progress, regarding cervical cancer, it should not be seen as a battle of diseases. It's not cancer against cardiovascular, and it's not hypertension against diabetes. So how can we find a common ground where we address the same NCDs? And again, one, looking at what exists at the moment. And then secondly, unfortunately, Africa takes also not only the good from high income countries, but also the bad. And when I'm talking about the bad, I'm really referring to the lifestyle. I'm referring to the diet, to the lack of exercise, to the smoking. So all of those, unfortunately, are getting to Africa and will make the whole burden of NCD actually much worse.
Yeah, thank you for that, Dr. Stefan. So Jessica Katz has a question. How can we start to build health system capacity to enable future delivery of more advanced treatments with proven efficacy, superiority, for example, immuno-oncology, while continuing to focus on equitable access to more basic cancer care?
I think, one of the questions which is related to this type of question, will you include precision oncology, for example, as part of global oncology? Should precision oncology be present in Africa? And again, there is a lot of controversy about it. Some of them, they would say, no, for sure not. We don't have even money, or enough funds, resources to, address basic problems. I'm on that group where I would say, yes, definitely we need precision oncology, because if we do not understand with what we are dealing, it will be extremely difficult to treat. So in other words, saying, if we do not understand well, our own ethnicity, our own population, and the type of cancers or any other disease that they are caused, we will not be able to adapt, and to adjust and give the right treatments, the right protocols in order to save that population. So, building the health system capacity, I think someone says Arbel is going to answer this question.
Oh no, she's just helping with the chat.
Oh, okay. So I think it's rather complex, but definitely, we need to go initially to understanding the situation before we are able to, to build on these health systems, which we know at the moment they weak, and it is what we have inherited.
Perfect, thank you. So there's another question from Jackie Namala. Hello, Dr. Stefan. Thank you very much for your insights. I'm currently taking a global health policy class, and something we were discussing was how the presence of a multitude of NGOs on the African continent can sometimes hinder coordination. Would you support having one main actor like the WHO, for example, that distributes personnel, or do you think having multiple organizations remains a better approach?
These are just extraordinary questions. They are not easy questions for sure. It's a difficult question because, of course, if we could have a better global coordination, that could help us tremendously. But I would give an example about, let's say, having several institutions involved in one country. So you have one small country with several institutions. And we have tried only in oncology, for example, in a country of 1 million or 2 million people, with 3 or 4 universities and 2 or 3 other NGOs, to bring them all to the table and to say, how can we coordinate? Could we have only one body that would be responsible to give, to give a global coordination for that specific problem? And it did not work. It did not work because, there were different interests and they were complementary. So one was really having more knowledge in one side of the things. The other one was, let's say, more into, sharing knowledge about health systems. On the other one was more knowledgeable in bringing teaching resources. So despite the fact that, I believe that a better coordination is needed, I don't know, and I don't think that WHO is the right actor. WHO is mainly involved. I had a chance to work with them. I think the role is different. But I think at the local level in one country, what will be important, really the ministries of health, the organization, the government organization, to bring everyone who is involved in that specific project to sit at the table and to really have an organogram or a table on which you could say, this one is in charge of this is in charge of that, and then they will complement each other. That would be my approach.
All right, thank you. So I will not be taking any more questions. Dr. Stefan lives in a different time zone, so we would have to sort of wrap up. But I'm just going to read the questions that are here now. So Fatima Diallo says, many countries in Africa lack the proper infrastructure and technology to administer screenings and provide effective treatments for patients. I'm interested to hear more about how Dr. Stefan addresses issues of inequity in her work. How are resources for cancer research and treatment negotiated?
So again, if you look in terms of cancer research, there were quite a number of papers published recently. Not as much is invested in cancer research in Africa. I think, again, things are changing. Science in general in Africa was not seen as a rewarding job, if you want to put it this way. I think the situation is changing at the moment. At the moment, we have more women scientists, we have more women researchers in Africa. So I think slowly this is changing. Regarding inequity, this is a tough topic because obviously it involves so many links and so many partners. But we do have quite a strong voice and we try to get everyone involved. It's easier if you deal with a specific disease, let's say childhood cancer, because the number is relatively smaller. You have already the WHO Global Initiative. But when we talk about inequity in general, it's not only related to a global issue, because it is so much more than that. So we are creating now new programs. We are trying to have collaborating institutions and partnerships with others. So slowly, you know, fellowships, people who are going overseas, people who are coming from overseas to us, and we are trying to prove what we are saying in terms of our research. And treatment is slightly different again. As you know, St. Jude, who is part of the WHO, tries now to give treatments to some of the centers in Africa, which is perfectly fine. But the question remains, what about when that supply goes away? What is it going then? How can we have a program that is sustainable, and perhaps, you know, having manufacturing and having genetic treatment, and also, you know, treating the right disease with the right treatment will perhaps help to answer to that question.
Okay, so an attendee says your story is so inspirational. Thank you so much for sharing it. I agree. Mirel Dizzy says, thank you so much for taking the time to speak with us today. I admire how you took your medical degree and followed your passions around the world. Can you speak a bit more on your life of a physician who has traveled across country barriers and how the certification and licensure process would be affected by this?
Yeah, it took a lot of energy, I must admit, and a lot of time. I enjoy doing it every single moment in time. I mean, I travel with my family and my children, so they followed almost everywhere. In terms of certification, some of the colleagues called me a nerd. I don't really like it at all, but I love exams, so it wasn't too difficult for me to go on to write my exams. I'm not certified everywhere, so there were certain countries where I would work but focus on a specific, for example, doing research. In South Africa, it's much easier, and Rwanda is much easier. But in Singapore, for example, I did not practice. I would still keep, you know, giving second opinions or seeing patients, you know, still in Africa to keep my license and my degrees, you know, present. So I think it is a balance on where you work and what you choose at that moment in time. So even when I worked for pharma, of course, I didn't need to work in Switzerland, for example, as a medical doctor, but I still kept my registration in South Africa, which for me was absolutely necessary.
Thank you. Alyssa says, wonderful presentation. Thank you. Last but one question. I wonder if there are any significant comorbidities that Dr. Stefan has noticed in her work. For example, has she looked at rates of communicable diseases as a factor in her oncology and equity work?
Yeah, so I mean, in my beginning, when I started with pediatrics and then with oncology, I focused quite a lot on infectious diseases. So comorbidities, again, HIV, as I have mentioned, one or two of the studies, and HIV malignancies, which was extremely important because you will have many children coming with HIV, infected with HIV, but then who developed cancer. And then again, I live in a country or in a region in Cape Town where TB, tuberculosis, is still extremely prevalent, and we do have children with TB, and more than that, we have multi-drug resistant TB. So definitely the association, the comorbidities between infectious diseases, and on top of this, of course, from time to time, you have malaria, maybe not as common in Cape Town, but, you know, in the northern side, or if you go up to Mozambique, to those areas, you have the malaria as well. So that adds to the complexity of the work.
Hey, Dottie Tran says, wonderful presentation. And the last question from Christine Chen. Thank you, Dr. Stefan, for all your insights. What are your thoughts on the rise of life sciences and medical consulting in recent years? What do you think are some downstream impacts they may have on the global health landscape, particularly in global oncology and equity?
So, again, medical consulting has good parts and maybe not as good parts. So you need to take the positive out of it. We need experts that they are able to bring inputs to and expertise to anything related to lifestyle. I think, global health landscape is still to be designed by us. I think global oncology, again, I wish to, perhaps have an academic career, and not compulsory, an oncologist would do global oncology. Again, global health is such a broad field where we need basically anyone, from social scientists, from, I don't know, politicians, anthropologists, nutritionists, physiotherapists. So all of them, there is no other way to move forward from my point of view when you talk about global oncology, except if you talk about in a comprehensive way. And when you look in terms of equity, think again, will the place where I'm born determine, or, the child that, grows or is born in a certain country will determine, the outcome of his life. So how can we make sure, because the world finally, is relatively small. So now, since we are moving from one country to another country, and since we are establishing all these relationships and partnerships, I would try to keep the focus in terms of, how could we reduce, and I mean, this would be sort of my last message for this lecture, perhaps encourage you all to think out of the box, come up with these ideas. How can we make it a fair world for all of us? How can we reduce these inequalities and gaps that affect all of us and will affect all of us? But I'm convinced that, this is why I said innovation definitely plays an important role. So we could go the traditional way, but I think in order to be able to tackle all these huge problems, we need to be more innovative, and we need to find new solutions.
Well, thank you so much, Dr. Stefan. I'm sure the panelists and participants will all agree with me that this has been very insightful. Thank you for spending your afternoon with us. So yeah, this is the end of the colloquium.
Thank you for the questions, and see you soon in Princeton.
I'll see you soon.